This material is also available as an accredited e-learning course. To access it, go to thrombosiscanada.ca/thrombosis-e-learning. Welcome to Cancer, Clots and Communication, a Thrombosis Canada education program.
This is the list of the steering committee made up of physicians representing hematology, oncology, and pharmacy who had involvement in development of this program. And tonight, the speakers listed here will be presenting this webinar information for you. Here are our disclosures. This program has received an unrestricted educational grant to support from Pfizer. There was no in-kind support provided by any organization. And with respect to conflicts of interest, all of the speakers here are eligible for honorarium from Thrombosis Canada, and Pfizer may benefit from products that we could discuss tonight. So with respect to mitigating bias or potential bias, the content was developed by the planning committee, peer-reviewed by Thrombosis Canada, and any recommendations in this webinar are evidence-based, and recommendations will conform to generally accepted standards. And the learning objectives for tonight, so at the end of this program, participants will be able to identify patients at risk for cancer-associated thrombosis, discuss risks of bleeding versus risk of clotting that may be associated with cancer and our cancer treatments, and describe educational resources to help patients and clinicians understand thrombosis risk and identify symptoms of thrombosis. I'll hand it over to Marc.
Thank you very much, Mary, and good evening, everyone. This presentation really stemmed from a survey that Thrombosis Canada started doing back in 2024. We really wanted to do a national survey on cancer-associated thrombosis directed to patients with cancer, but also those who care for them. The survey was designed to assess really trying to figure out, do patients have knowledge on the different aspects of cancer-associated thrombosis? And we asked a number of questions that we'll go through together. Unfortunately, and that made me cry a little bit, you'll see that we really found that there's a lack of clinical awareness and knowledge on cancer-associated thrombosis, which makes me want to roll up my sleeve, and it really highlights that there's a need for ongoing education, providing awareness to both providers, patients, and their loved ones. And we'll try to go through the different components today, through the different questions, and see what thrombosis has to offer. So the survey that we did was developed by 4 clinicians specializing in cancer-associated thrombosis, Dr. Agnes Lee from Vancouver, Dr. Vicky Tagalakis from McGill, Dr. Rufero Chitsiki from Memorial University, myself, and we had a patient partner with lived experience, Susan Keverly, that was very helpful in trying to frame the questions and really trying to get at what we wanted to do. The survey was over 2 months from May to June 2024, and you can see that we had over 300 respondents in the end that were helpful to do the survey. So if we look at the characteristics of people that actually filled in the survey, you can see that about 60% of people were women, most people were from Ontario and Quebec, and then most people were actually English speaking. 74% of respondents identified English as their language and 20% French. What we found very interesting too is up to 7% of people had another language as their first language or the language they were speaking at home, which may have implication when we talk about accessibility, awareness of information and resources. And Thrombosis Canada is trying to really dive down and try to have translations for other language that are spoken in Canada so that we can really reach out everyone and make sure that everybody's aware about cancer-associated thrombosis. So one of the first questions we asked patients and loved ones was really how familiar they are with terms related to venous and arterial thrombosis. So we asked them, when you think about blood clots, which of the following do you think of? And you can see here, looking at red and blue, that venous thrombosis is really not at top of mind. Most respondents, more than 50%, thought that blood clots were related to DVT or PE, whereas over 70% of people thought that strokes were related to PE. And so that strokes were related to blood clots. So really focusing the fact that patients don't really have a lot of awareness on venous thromboembolic complications. And when we think about blood clots, we thought of arterial, that's important, but in the setting of cancer, it's really venous disease as an important, and maybe we should focus a little bit of efforts on having healthcare providers and patients being aware of venous thromboembolic complications like DVT and PEs. We also asked them if they were understanding the medical terminologies, so if they were familiar with terms like DVTs and PEs. And you can see here that when we think about venous thrombosis terms, it was very low for many respondents. Most of them selected having no knowledge about DVTs and PEs, really again suggesting that we need to roll up their sleeves and try to do better when we talk about cancer-associated thrombosis. We asked specifically if patients living with cancer had knowledge about cancer-associated thrombosis, so including venous disease, DVTs and PEs into a broader term of CAT or cancer-associated thrombosis. You can see here it's low. 38% of responded reported having no knowledge of cancer-associated thrombosis, and then more than 50% have very low knowledge about cancer-associated thrombosis overall. We also asked them if they received some education, and you can see here from the circle that thrombosis education seems to be inconsistent. Only 30% of responded recall receiving education about thrombosis signs, symptoms, but from their healthcare team, which is highlighting the importance of not only providing some feedback to patients, but also to providers, healthcare providers, physicians, nurses, GPOs, pharmacists to be included in the discussion at a different time in the cancer journey so that we can increase awareness accordingly. When we ask if the healthcare team informed them and when did that happen, you can see maybe that thrombosis information this sometimes happen, although across the board being relatively low, but you can see that while the majority of patients undergoing active treatment did not recall, it's still higher than when it was completed, maybe suggesting that people tend to forget about venous thrombosis and CAT associated information as the cancer journey is ongoing, and maybe we should be mindful of repeating. Sometimes repetition is key, and having checkpoints during the cancer journey when they have a line inserted, when they get chemotherapy, when they're meeting pharmacists and doctors and nurses in order to reinforce the message so that they keep that in top of line and they know when to seek medical attention when they need it. We also ask patients, like, do you care about this? Is this something that you would like to know? Well, education on blood clots seems to be highly valued by our patients. 44% of respondents rated education on blood clots from their healthcare provider as extremely important. Most of them thought it would be very important to have some form of workshop. And obviously, healthcare providers seems to be playing an important role into that. What do the patient really want to hear about? Well, most of them want to have information about the risk of thrombosis with cancer. We'll talk about that a little bit. They also want to have information on the risk factors for thrombosis associated with cancer specifically. They want to know the pros and cons of starting anticoagulation for primary prevention, side effects, what's the risk of bleeding. So all of these things are important to do. Most of them would like to have their information through webinar, on print, and different venues that here at Thrombosis Canada will try to make sure that we can go through and provide that to our patients. So before moving forward to the next session, I guess we have a polling question. Are you surprised by these results? Is this something that you feel is consistent with what you have in your clinical practice? Maybe you already know that there's not a whole lot of clinical awareness about cancer-associated thrombosis. Maybe you do it on a regular basis, so you're surprised to know that patients don't necessarily retain or keep that information over time. Or maybe you say in between, you're not overly surprised. Maybe only high-risk patients should be aware of these things. So we'll take a couple of seconds to answer the question. Okay, so a large majority of the audience say, I'm not surprised. Most people don't necessarily know too much about venous thrombosis in the setting of cancer. And that's important because as we've been mentoring and we'll go through incidence and risk factors, these are important to keep in mind because it's something that is common, increasing over time, associated morbidity and mortality, and therefore we should be mindful of that and reminding our patients on a regular basis. Okay, a second question. How accurately do you think this data represents your practice? Do you think that what I've shown you is somewhat similar to what you've seen in your clinical practice, somewhat not accurate, or not accurate at all because you feel that your patients may have more awareness than what was shown? So are we painting the right thing for clinical practice in Canada? And as I was expecting, most of you think this is accurate or somewhat accurate. And now let's have a look at some of the data and see how we can change these things over time. And I'll pass it to our next speaker.
So most of us would know, I think and hope, that our patients with cancer have a higher risk of clotting than the general population. And that's in the range of 9 times. So in the first 12 months after a cancer diagnosis, a cancer patient will have a risk of clotting of 2.3% versus in that same time period, the general population 0.25. And the risk factors would be previous clot, metastatic disease, and then their systemic therapy would be a big factor. So chemotherapy, targeted therapies, anti-angiogenic therapies, and immunotherapy, which has been a massive change in our practice with many patients receiving immunotherapy. And if you look at the right side of the slide, it's that the GI, heme, ovarian cancer are the most prevalent sites for clotting. But when you look at the different bars by color, you can see that there's been an increased incidence over the 20 years that's shown on this graph for clots. That partially is due to better screening, we're doing more scans more frequently, finding more incidental clots, and we're giving patients more treatment. They're getting more lines of therapy, they're living longer, and so they're at risk for clotting over a longer period of time. So there's definitely increased incidence over the 20 years that's included on the right side. And then this graph just looks at that in a somewhat similar way, looking at months from diagnosis and the cumulative incidence. So you can see on the bottom, the red line is if someone's diagnosed with cancer but gets no treatment, that would be their incidence of developing a VTE. But as you start to give them systemic therapy and different therapies and combinations of therapies, that incidence of clot is going to go up. So approximately 15% of patients with cancer will develop a clot at some point. And when I see a new patient in consult, tell them that 1 in 8 people will develop a clot, that cancer, chemotherapy, access devices are all individual risk factors. So they have 3 automatically if we're treating them systemically. We also know that if somebody has a clot, they're more likely that we have to think about metastatic disease. So if they're presenting with a clot, maybe don't have a diagnosis of cancer yet, to look for a diagnosis of cancer, and that our patients are at higher risk of recurrence and bleeding complications than for patients who do not have cancer. And this slide addresses fatality rates, looking at, are you more likely to die from recurrent VTE versus major bleeding if you're anticoagulated with a cancer-associated thrombosis? And it is, the incidence is higher, the case fatality rate is higher for recurrent VTE versus bleeding. And this was a study looking at, they looked at 29 studies over from 1980 to 2019, 8,000 patients were included in the studies, and there was no statistically significant difference between the anticoagulants. So we need to keep this in mind when we're thinking about treatment and weighing risks of treatment versus bleeding.
Yeah, I'm going to take over the next part. We're going to talk about prevention of cancer-associated blood clots. So we have a couple of questions. The first is, who in your practice assesses patients for blood clots or the risk of blood clots in your practice? Is it a nurse or nurse practitioner, a pharmacist, the oncologist, hematologist, a resident or a fellow, or variations of the above? Yeah, I think variations of the above is obviously by far and away the biggest answer, and that would be true in my clinic too. But the oncologist in our center has a fairly significant role along with our nursing staff. We're all trained. Next question. When and how often are patients with cancer-associated thrombosis or at risk of thrombosis? Sorry, let me just rephrase that. There's a window on my screen here. When and how often are patients with cancer assessed for thrombosis or risk for thrombosis? Number 1, at diagnosis. Number 2, at the start of treatment. Number 3, every visit or interaction. Number 4, depends on the patient and the cancer. Or number 5, variations of the above. Okay, again, variations of the above, with the majority saying, other than variations of the above, that it depends on the patient and the cancer. In our hospital, our nursing staff who see the patients first are trained to ask patients about signs and symptoms of blood clots, but we've made a fairly intentional effort to try and do that. There is a score called the Khorana risk score, which many of you will have heard of. It is a stratification score to look at patients who are ambulatory cancer patients who are receiving chemo and looking at their risk of developing a blood clot. There are 5 key factors to this. The site of the tumor is the first. Very high-risk cancers are stomach and pancreas. And I think if you were to look at some of the data that Mary just showed, maybe there's some new data suggesting that some of the other cancers like hepatobiliary cancers like liver and biliary cancers might also be a high risk. But for this score, pancreas and stomach are very high risk. High risk are lung, lymphoma, gynecologic, bladder, and testicular cancers. For a very high risk, the score patients are given a score of 2. And for high risk, patients are given a score of 1, and everyone else is given a score of 0. Second key factor is the pre-chemo platelet count being 350 or higher, hemoglobin count of less than 100 or the use of ESAs, the pre-chemo white blood cell count being over 100, and a BMI of 35 or over. Those last 4 all have a score of 1 if they're positive. If all of them are 0, if the score is 0, they're low risk, and their 6-month risk of developing blood clot is 1.5%. If they score a 1 or a 2, so someone with, for example, a pancreatic cancer already is an intermediate risk, it varies between 4 and just under 10%, and 3 or higher, just under 18%. So these are higher risk patients. Thrombosis Canada has a calculator for the Khorana risk score, and you can see it here on the slide. Very easy to use, and I recommend that you use it because it's easy to access and, again, easy to use. The ASH 2021 guidelines have some thoughts about how to use the Khorana risk score. Patients at low risk of thrombosis, so a score of 0, no thromboprophylaxis is required. But an intermediate, they recommend either a DOAC, apixaban or rivaroxaban, or no thromboprophylaxis. And that's based on moderate certainty. And then patients with high risk of thrombosis, scores of 3 or higher, thromboprophylaxis using a DOAC or a low molecular weight heparin is preferred over no thromboprophylaxis. And again, that's based on moderate certainty. Why do this? I think it's pretty clear. Patients who develop a blood clot, this is a distressing experience, and for some, a traumatic experience. There's often little support or little knowledge, as shown by Marc's survey. This increases patients' sort of focus on their own cancer, and for some have reported like a decreased willingness to sort of engage outside of themselves because they're so focused on themselves, and additional stressors such as cost. In many cases, patients have to pay for these drugs. The risk, of course, with prophylaxis is going to be bleeding. So you have the risk of both the clot and bleeding, and both of these are what need to be weighed. Both can reduce the quality of life, increasing resource use and ultimately resource cost. So what to choose, a DOAC or low molecular weight heparin? This is a very nice sort of simple algorithm to help decide. If a patient is at higher risk for bleeding, whatever the cause, they have a high risk for medical reasons, the high risk GI lesion, they have a low platelet count, kidney or liver dysfunction, they're on an antiplatelet agent or a recent stroke. If any of those are yes, then the low molecular weight heparin would be preferred. Depending on the type of tumor matters too, and unresected intraluminal GI or GU cancer, higher risk of bleeding, a low molecular weight heparin would be preferred. And if there's a drug-drug interaction with a DOAC, a CYP3A4 or P-glycoprotein interactions with any of the drugs, then again, a low molecular weight heparin is preferred. In our own institution, our pharmacists will do, once we've decided on the chemo, our pharmacists will do a check on drug-drug interactions and then let us know particularly if a patient's coming in on a DOAC. And then if the answer to all of these is no, then the DOAC is the preferred drug of choice.
Alrighty, so let's continue the discussion about drug interactions. As we know, interactions are very common among patients with cancer-associated thrombosis, and we sometimes face the question of whether drug interactions may lead to adverse events. The cited observational study included 267 patients, and it found that over 40% of them had a drug interaction between their anticoagulant and another medication they were taking. The prevalence of those drug interactions was much more profound in the DOAC group, around 50%, compared to the low molecular weight heparin group at 19%, which was statistically significant. So we should always consider clinically relevant drug interactions when we're evaluating whether or not to use apixaban or rivaroxaban for primary thromboprophylaxis in our ambulatory cancer patients. For example, medications that are strong inhibitors of both the CYP3A4 and the P-glycoprotein can significantly increase the overall exposure to these DOACs, so therefore increasing the risk of bleeding. And conversely, medications that are strong inducers of both the CYP3A4 and P-glycoprotein can significantly decrease the overall exposure of these DOACs, which can reduce their efficacy in preventing VTEs. So both strong inhibitors and inducers of 3A4 and P-glycoprotein are not recommended with apixaban and rivaroxaban, and a pharmacist should be involved in assessing a patient's medications, including their cancer treatments, to see if DOACs are an acceptable therapy for thromboprophylaxis. Otherwise, we may want to consider low molecular weight heparin. I'd like to highlight this resource from the Thrombosis Canada website. This drug-drug interaction tool is available to help guide DOACs when used in combination with other drugs. The table format lists out each DOAC and interacting medications, providing a summary of the recommendations. So as an example, apixaban and ketoconazole are listed as contraindicated. And historically, drug access and coverage had been a concern with DOACs, but now apixaban and rivaroxaban are available in all provinces and territories across Canada. So rivaroxaban does have restrictions in Saskatchewan. A program I'm looking forward to highlighting is the venous thromboembolism prevention in the ambulatory cancer clinic, which is a multidisciplinary program including nurses, oncologists, pharmacists, hematologists, and advanced practice providers. To provide an overview of this clinic's format, so first, a risk assessment tool in the electronic health record will prospectively identify high-risk outpatients who are initiating their anti-cancer therapies. And this is done by selecting patients with over 3 points on their Khorana risk score. And then patients are offered a hematology consult to consider VTE prophylaxis. Some of the important considerations, which are discussed using shared decision-making, include things like bleed risk, drug interactions, and anticoagulation recommendations. And then finally, results of the consultation are communicated to the treating oncologist and the clinical outcomes have been tracked. And so this graph shows education rates of the patients included in this initiative, which was evaluated over the course of 2.5 years. So as we can see at the start of the graph, VTE risk assessment and education rates were under 5% before the VTE prevention clinic began. And then over the course of the implementation phase and post-implementation, the education and risk assessment rates increased to over 95%. So post-implementation, 23% of patients screened were deemed to be high risk for developing a VTE based on their Khorana score. And these patients had a 12.8% risk of VTE during the implementation phase. Of these high-risk patients, 71% of them were referred to a hematologist, a pharmacist, or an advanced practice provider who was part of the thrombosis and hemostasis program, and 93% of them attended a clinic visit for an assessment. So the major clinical outcome that was tracked with this program was VTE in the first 6 months of therapy. And while that data is not yet published, I can say the data is showing this interprofessional clinic model resulted in a reduction in VTEs. And this data was presented at the ISTH, or the International Society on Thrombosis and Hemostasis 2025 Congress, and it will be published very soon. Overall, multidisciplinary management will offer the best comprehensive approach to antithrombotic care. We should also be constantly reevaluating the risk of thrombosis, as this will vary during the patient's cancer journey. And we can count on clinical pharmacists to help navigate drug interactions. And we have many resources available to help guide education with patients and caregivers. So I'll transition back over to Marc to cover some of these resources.
Thank you, Michaela. And I'm so encouraged that we finally have data showing that if we provide awareness, we do education, not only are we increasing patients to know the signs and symptoms of DVT, when to seek medical attention, ask about maybe having some ways to prevent them, but we're actually, now there's documentation and proof that we decrease the risk of venous thromboembolic complication, no increasing the risk of bleeding. It means that patients' awareness and caregiver awareness and providers' awareness actually works. And then we can really make better things for patients and decrease morbidity and mortality associated with these things. And of course, this goes a long way. Thrombosis Canada has many resources in the setting of cancer-associated thrombosis. There's actually a CAT patient library to support patients with cancer and provide information about the risk of cancer-associated thrombosis, signs and symptoms associated with these, when to seek medical attention. And this is just one of many additional resources that we have. So you can see here we had a short information webinars if you're interested. We have patient information booklet that I use quite a bit in my own clinic when I have patients, and then I start thromboprophylaxis or primary thromboprophylaxis based on what Jay has mentioned before. I would encourage you to visit the Thrombosis Canada website to have a look at these different resources, and then maybe some won't be too much of a use, but sometimes maybe we can find something that we incorporate in our flow and the clinic practice, and that may be very helpful. And we now know that's decreasing the risk of VTE and maybe mortality in these patients. So there's also, although not specific to patients with cancer, Thrombosis Canada has worked really hard in partnership with the National Blood Clients Alliance to have a new patient guide which offers education and insight into various aspects of thrombosis and all that applies to patients. Like patients often, when they have a venous thrombosis, they may have a lot of different questions. We're obviously busy in clinics. Sometimes they don't think about all the questions that are important to us. So I would really suggest that you have a look at this guide. I use it for all my new clots now, independent if they have cancer or not. There's a lot of information, a lot of frequent questions that are asked, and I think it's also providing a lot of good reassurance to patient. And often we see patients in follow-up, they've been not exercising or they've been doing some things because they think it's better or not, or they're worried the clot may embolize. I think this particular resources is very important to provide them with good evidence-based answers to all their questions that they have. Obviously, there's nothing like a patient support group. There are different types of group that we can refer patients to. There's no specific groups for venous thrombosis, but Thrombosis Canada is slowly working on that over time. But if you have any patient information or support group, please add it to the chart so that we can share the resources across Canada. And then finally, if you're a clinician, you're probably aware that we're very famous for clinical guides. We have 53 clinical guides overall, 4 algorithms, 12 calculators. These are highly used, and then I would recommend that you go and see them. There's some specific for cancer-associated thrombosis, but also patients with cancer also have all sorts of different types of clot that may not be the typical one, not necessarily a proximal DVT or PE. So we have resources on interruption of anticoagulation, superficial vein thrombosis, and usual site thrombosis. So these are meant for primary care docs, busy internists, oncologists. They're one pager and they give you exactly what you need to know, and a short summary of the literature, and hopefully a guide on how to approach these different things overall. We obviously also have calculators. I've put it in the chat for people. There was a question, do we have a calculator on how to make a decision about using a DOAC or a low microwave heparin? I was mentioning it would be great to have that. Maybe Jay can have this new role of just answering all the questions when people were wondering if to use a DOAC or low microwave heparin. But as I mentioned, there's so many factors affecting that clinical decision. It's really hard to put that into an algorithm. But we do have additional tools. So this is one of the clinical tools, a brand new feature. We mentioned that maybe we want to stratify patients according to their underlying risk of having VTE. The Khorana risk score was highlighted. So now we have the Khorana risk score calculator on our website, and that may be important for you to make a decision about discussion about thromboprophylaxis or not, incorporating it or not, or maybe just providing education to these patients. And finally, we have a very rich e-learning platform which offers several accredited courses on various thrombosis topics that range from 30 to 90 minutes. They're all accredited, so I would welcome you to have a look, and some are very specific to cancer-associated thrombosis, but if you have an interest, there's other things for you to look into as well. So hopefully that will help to generate some awareness and education around it and give you some ideas on how to manage things further. So maybe if you, as we're starting slowly to discuss, go through the Q&A to get your feedback. What is your go-to patient education resources? Added to the chat feature. Let us know what you usually use, what you don't like to use, because sharing best practice is the only way that we can move the field forward. So I learn all the time as I'm listening to these webinars or participating into them. I have always new tricks that can help me to do clinic tomorrow. So please don't be shy to add some of the things in there. So before we go to the Q&A, we'll ask a couple more questions. What format resources do you prefer to share with patients? And that will help us to work on future projects to really have things that are tailored to your needs to help patient education and awareness for cancer-associated thrombosis. I'll give you a few minutes to do that. Okay, so printed brochures and materials seems to be the winner, and then online resources. So that's important for us. So maybe we can work on printed brochure material and also put them online so that you can use them and print them as you see fit. Maybe some interest for videos, but I think we're all tired of having a new app. So maybe we'll not do that for the time being. Okay, we'll open up to questions and discussions, and I'll try to engage, try to go through a different question. Maybe I'll start with you, Michaela, because one of the questions earlier on was how do we engage other healthcare providers, pharmacists, for example, in your line of work. Michaela is one of the important oncology pharmacists at the Ottawa hospital. So what's the role of a pharmacist to help with patient awareness in that setting?
Definitely the pharmacist could play a role in patient education, and at our center, I work on the inpatient unit side, so every time I have a patient with a new start on a new treatment, I review the treatment with them, and as part of that, one of the things I review are the signs and symptoms of bleeds and clots, just to make patients aware that it's not uncommon and that they should know what to look out for and what to do if something were to come up. We also have a patient support line that we give patients information for, so that if they do notice something out of the ordinary, they'll have some support once they go home on the outpatient side, and they can always call in and get advice. So that's a great resource for patients to use.
Fantastic. Thank you, Michaela. Mary, I'll give you this one. Is the hope that CAT education for patients occurred upon diagnosis and within the cancer center and with the cancer healthcare providers or specialists? Or do you also hope that primary care physicians will educate and start patients on prophylactic treatment? I mean, providing signs, symptoms, and prophylactic, or should it be both? What do you think?
I think it should be both. Like, we should be talking to our patients, reminding them. I think we do a fair job of it. We probably just don't vocalize that I'm assessing you for a blood clot around the questions. If someone comes in and says, I have a swollen leg, or I have some shortness of breath. So there's an assessment happening. Perhaps we're not educating them vocally with saying, well, it could be a blood clot, could be X, could be Y, could be Z. So that definitely. I think as far as thromboprophylaxis, I'm not sure how many family doctors would be comfortable initiating that. I would probably as well make use of my thrombosis clinic in the hospital to say, hey, I've assessed this patient. I think they might be a candidate. Would you please get involved and give me your opinion?
Okay. And then that's something that maybe, Jay, you'd be happy to help with primary care docs to make that decision.
Yeah, oh, for sure. And I think to Mary's point, I think I would actually prefer if it was done in the cancer center in a sort of a controlled environment where we also know the other drugs that are going to be added. Would be my own personal preference, because we're going to have updated lab work, all of those things that we need to do to assess clinical status. And I guess it depends on the wait time to get into the cancer center. I mean, if it's a long wait, I think that's more reasonable, but certainly in our center, the way things are flowing, I think we would rather make that decision, especially because of the potential for drug-drug interactions, which may not always be considered. It's not just chemotherapy, but a whole slew of other drugs can interact with these drugs, with the DOACs in particular.
Yeah, but the primary care doc can still play a key role in patient awareness and prompting the medical oncologist. You guys are busy, so sometimes you don't necessarily need or have time to talk about all the potential consequences. The plate is already full, so how do you add something more on the discussion is sometimes hard.
Yes.
And John kindly shared with us an update that he's using. So he's using the JAMA patient info page, and he seems to find it very helpful over time. So that's fantastic. Jay, this is maybe a question for you as the oncologist. So when you make a decision about primary thromboprophylaxis, how do you incorporate the bleeding risk into that decision? Do you use a certain tool like the ASBLED, or do you use your clinical gestalt?
You know what? It's a clinical gestalt, and it's more of a time factor when we do it. So I treat GI cancers. So pancreas, for example, is one of the cancers that I would treat. When that conversation is happening, patients are informed about the bleeding risk. But we also talk about that in the context of thrombocytopenia because of the chemotherapy that we cause. So we pay a lot of attention to that bleeding risk.
Yeah.
And in the data that Michaela mentioned from Vermont, the VTE Pact, they use the ASBLED to try to risk benefit. But it's important to keep in mind, I agree with you, Jay, there's no risk stratification model or scores that have been validated in the setting of VTE. There's some that have been derived for cancer-associated thrombosis, trying to predict bleeding, but it's mostly for therapeutic dosing. It hasn't been validated, so we don't have any tools yet that are really for prime time to help. And that might be an important roadblock. Medical oncologists may not feel as comfortable, pharmacists may not feel as comfortable to assess the bleeding risk. So providing reassurance about the small risk of having bleeding complication may also be very important. Michaela, do you agree with Jay? Do you use something specific when you try to assess the bleeding risk when you have a discussion with patients?
Also very similar sentiments there, that we can calculate the HAS-BLED and kind of use it as a guide, but at the end of the day, we're looking at the patient as a whole and kind of a case-by-case scenario based on their specific risk factors.
And when you try to assess for drug-to-drug interaction, which tool is the best tool to use? What's the secret from pharmacists?
Well, some of the Thrombosis Canada resources I will plug there. They have some great charts that outlines each DOAC and then listing out all the medications and what the Thrombosis Canada recommendation is with combining them. Sometimes I find it's hard, especially as new drugs are constantly coming to the market in the oncology space, to know what enzymes might be induced or inhibited but I like using the LexiComp section on like pharmacokinetics, where you can look at interactions and it will list out what enzymes are induced or inhibited by a specific drug. So you can look at drug specific if it affects 3A4 or P-glycoprotein, for example. That's another good trick to use.
Okay. And thank you, Michaela. Jay, is the Khorana risk score effective? Is it a good score to use? The question was specifically, hold on, I saw it coming, but what are the metrics of not the metrics, but is it a good score to use?
I think it's a very good
accurate and reliable the Khorana risk score is.
I think it's a very good score to use. I think the reality is that it's probably not used as much as it should be. I think for two reasons. One, the whole conversation, I mean, as your survey showed, patients aren't necessarily being taught, and this isn't necessarily a discussion. And I wonder if it's because physicians, this isn't necessarily top of mind when you're talking about an immunotherapy and all the catastrophic things that can go wrong with that, as an example. So I wonder if, so an excellent score probably not being used as much as it should for a variety of reasons.
Yeah. There's to answer specifically and complement what you said, Amber, there's a systematic review that looked at the accuracy of the Khorana risk score. As Jay mentioned, it's very accurate. Of course, we probably need a score for every tumor type in every stage because the cancer journey is so different. But the Khorana risk score has pros and cons, but it's an excellent screening tool. It has been shown over and over again that you can stratify patients reliably with the score. So something at least you can use the features of it to try to at least identify patients that may be slightly at higher risk. Thank you, Jay. Mary, this one's for you. Chris has dedicated CAT clinics in his center. I'm not sure if you do in yours, but it's usually for treatment. Should we rethink CAT clinics and have them see patients for primary prevention? Would that be something that could be helpful? Like new diagnosis, recurrence, should they be on it or not? What do you think?
I think that would be a lovely addition to any clinic, and the physicians would be thrilled to refer, because I think, like Jacob's saying, the clinics are busy. There's lots of patients, there's vacations, there's unexpected things that come up, and you don't have a lot of time to sit down and have a lengthy discussion about something. So if there's a clinic designated for thrombosis, there's a team that does that, is there to help you with that assessment and treatment. Yeah, definitely people would love to take advantage of it for sure.
Yeah. Taking something off the plate of the oncologists or the GPOs or other pharmacists to have a dedicated.
Also, maybe it could be incorporated that new consults, they're triaging them for their risk, should they be considered for thromboprophylaxis. So it could be, you could evolve that if it was fully functional and well staffed, and because it's definitely a need for sure.
And then maybe a question that is slightly different, but Kira had asked, what if a patient has a PE and in the setting of cancer, do we have any way to stratify who should be admitted, who should be discharged home? This is a loaded question because often when emergency room docs and internists are making decisions of admission or not, they use something like simplify PESI criteria, ISTIA criteria. But if you have cancer, you already have almost a high risk on its own. So do all cancer patients need to be admitted to hospital? No. But we don't have specific criteria other than using your clinical judgment, making sure you don't require oxygen, they don't have another reason for hospitalization, they're not tachycardia over 110, they have a good blood pressure. These types of things are things that we continue. But to be reassuring, there's a randomized controlled trial in France called Home Cancer PE, where they're randomizing patients to early discharge or managed in the outpatient setting versus hospitalization. So we'll soon have data in order to provide some reassurance about treating some of these patients. It may also be a big difference depending on the logistic that you have. If you have a CAT clinic, if you have thrombosis, if you have good follow-up, that will make a big difference if you need or need to hospitalize these patients or not. Okay.
I'd say that's pretty uncommon in my experience of needing to hospitalize people I would say the majority of our patients are treated as outpatients.
Yeah, you're quite right. We're trying to be aggressive. Hospitals are already full, so it's important to keep that in mind. Jay, a question. Is the Khorana risk score only for ambulatory patient or for both inpatients and outpatient?
And my understanding is it was designed for the ambulatory setting, but I'm just not sure if there's any data to support its use in the inpatient setting. But it was originally designed as an ambulatory score.
Yeah, you're quite right. It was originally designed. There's a few studies, retrospective studies, trying to see if we can use it to try to predict in patients as well, but never been validated externally. So it's unknown a little bit if they would be reliable to do so. So probably using improved score, other scores that we usually use in the inpatient setting may be better for the time being until we have further validation in that setting. Okay. And then Mary, maybe, or Jay, this is for you. How many you modify the Khorana-based decision to anticoagulation when the platelets start to drop, or if you anticipate starting a drug that will cause bone marrow suppression? What do you do, Jay? Do you hold off on thromboprophylaxis if you expect some myelosuppression?
That's a very good question. Thinking about pancreatic cancer, for example, the best chemo we have is FOLFIRINOX, and that is very myelosuppressive. And so here's a patient where you potentially are going to make them thrombocytopenic, and they have a risk, at least an intermediate risk, because they're pancreatic cancer patients. Yeah, this is a conversation. I'll tell you what I do in most cases is I actually err on the side of just watching them. And because for some patients, the drop in platelets can be pretty impressive, and it's too late to kind of come back from that. I don't know if there's a good answer to that particular case for an example, but that's just what I've been doing.
I completely agree. And creating awareness is also saying or telling them when it's time to seek medical attention, right?
Yeah.
Because we had that discussion before that patients have all sorts of symptoms. If they don't know they're at risk of clot, they think their symptoms are related to chemotherapy,
Exactly.
therapy, or maybe related to the underlying cancer. They don't think they can have a clot. So remind them of the signs and symptoms may be helpful in that particular setting. So we're almost at the top of the hour. There's just one more question that I think we did have the time to address is, should we use thromboprophylaxis for central lines? And I think it's still a little bit unknown for the time being. There's randomized controlled trial randomizing patients with central lines, a Khorana risk score not necessarily high to receive thromboprophylaxis or not, i.e. is centralized an independent risk factor for cancer-associated thrombosis. So for the time being, clinical practice guidelines don't recommend it routinely in practice unless your patient obviously is Khorana risk score of 2 or more, but future trials may help us to tailor that particular practice. So with that, Michaela, Mary, Jay, thank you so much for taking time out of your busy days, practice, life to spend time with us. I think we had a very wonderful discussion. I certainly learned a lot and really appreciate you providing your insight in that particular for the webinar.